The following podcast is part of a certified educational activity titled Renovating Frontline Care for Metastatic Melanoma, Guidance on Upgrading to Combination Immunotherapy Standards Across Disease Presentations. Access the entire activity and complete the post-test at peerview.com/RQT860. Downloadable slides and practice aids are also available.
Hello and welcome to Renovating Frontline Care for Metastatic Melanoma, Guidance on Upgrading to Combination Immunotherapy Standards Across Disease Presentations. My name is Hussein Tawbi. I'm Professor and Deputy Chair of the Department of Melanoma Medical Oncology at the MD Anderson Cancer Center in Houston. And today I will focus on the emergence of combination immunotherapy as standard of care management option in metastatic melanoma, and specifically explore the role of PD-1 LAG-3 and other combinations in different patient populations. After reviewing recent evidence in this area, I'll share several cases to illustrate how we use these combinations and explore practical dosing and safety management considerations. During this program, we'll periodically share several resources summarizing practical aspects of immunotherapy combinations in melanoma, so please take a moment to download those tools before we get started. Let's begin. So this is a summary of the last 10-12 years of drug development in metastatic melanoma and specifically highlights the overall survival improvements since the era of checkpoint inhibitors started with the anti-CTLA-4 antibody. And while that was a major breakthrough, it is fascinating to see how it is the worst survival curve we have here because of the advancement we've had since then, both with PD-1 antibodies, the combination of PD-1 and CTLA-4, which really comes on top of these several options. And then you see also the role of PD-1, BRAF, and MEK inhibitors as well. So at this moment in time, our patients with metastatic melanoma have a median survival that's closer to 72 months, especially with combination checkpoint inhibitors. If you review the NCCN guidelines for treatment of metastatic melanoma patients, you will see that in the first line setting, all of those regimens that I just went through are FDA approved: PD-1 alone, CTLA-4 alone, the combination of PD-1, CTLA-4, now PD-1 LAG-3. You also see the BRAF and MEK inhibitor combinations and low-dose IPI-Pembro. But what's clear is that the preferred regimens are the combination checkpoint blockade. And we'll review some of the data leading to IPI and Nivo being upfront, namely Checkmate 067 and DreamSeq. And also we'll review Relativity 047, which also led to Category 1 assignment for Nivo and Rela in the first line. Unfortunately, despite the fact that these are recommended and preferred options, a look at the nationwide real-world evidence indicates that not every patient with metastatic melanoma is receiving combination immunotherapy upfront. And we see that this has really changed dramatically from 2010 to 2019. But there's still almost 40% of patients that are not getting first-line immune checkpoint inhibitors in 2019, although we know that this is associated with substantial improvements in overall survival. So those rates remain suboptimal, and hopefully as we go through the data today, it will be clear why this is the preferred choice for our patients with metastatic melanoma. There could be some concerns for this being related to access to a degree as well, and concerns about potentially age and comorbidities. And if you look at this data from almost 10,000 patients with metastatic disease, it seems that increasing age and high comorbidity are some of the factors that lead to less use of checkpoint inhibitors in those patients. And we have a specific example from my state of Texas where older age is associated with decreased use of checkpoint inhibitors, but also high poverty neighborhoods, again, reflecting the potential issues with access. So our goals of today are to improve our knowledge of updated guidelines and evidence supporting the use of immunotherapy for the frontline management of unresectable metastatic melanoma, and specifically provide you with guidance on using immunotherapy platforms for the personalized management of newly diagnosed patients, and equip you with the skills that you will need to address dosing and safety considerations with immunotherapy regimens in the melanoma setting. The didactic component of this is titled Modern Principles Informing the Frontline Use of Immunotherapy Combinations. and we'll start with Relativity 047. This is a clinical trial that explored the combination of PD-1 and LAG-3 compared to PD-1 alone. So LAG-3 is an exhaustion marker that's expressed on activated T cells, and it usually is co-expressed with PD-1 and a more reduced ability of those T cells to clear tumor, to kill tumor, to produce cytokines, and to produce effector memory cells as well. And preclinical experiments had shown that if you combine LAG-3 with PD-1, you actually get a much better outcome compared to single-agent PD-1. And this phase 2/3 trial was designed specifically to address patients in the first-line setting, previously untreated melanoma, randomized 1-to-1 to either receive PD-1 lag and specifically nivolumab at 480, relatlimab at 160 milligrams compared to nivolumab alone at 480 milligrams. And this study went in 2 phases. The phase 2 component had about 400 patients, and after a 6 months pause went on to another 315, so a total of about 714 patients enrolled. And what you see here is that the PFS is clearly different. From the first time you check a scan, there's a difference between the combination in favor of the combination over single agent PD-1. And that is maintained and sustained all the way almost to 4 years now. And we have this 3-year median follow-up that we just presented at ASCO. The hazard ratio is 0.79, clearly statistically significant. The median PFS is 10 months versus 4.6 months. So this remains very consistent as we update the data with the longer follow-up, especially for the second wave of patients that came into the phase 3 component. And if you look at the specific subgroups, because that's how we personalize therapy, we think about, are there any subgroups in which there is more benefit than others? And frankly, what you see from this is that the benefit is consistent across almost every single subgroup. You get about a 10% improvement in response. Again, we have the same hazard ratio for the PFS. Whether the patients are old, it doesn't really matter. More than 75, you still get that about 10%. In this particular case, it was 13% improvement in objective response. If they're BRAF mutant melanoma or not, it doesn't make any difference. In fact, PFS and objective response and OS almost look identical in terms of whether patients have BRAF mutant melanoma or not. And LDH levels don't matter either. So even if it's a higher LDH is associated with worse outcomes in general in melanoma, we know this across the board, you still could get benefit from the combination over single agent PD-1. And one other point on this graph that will become relevant later is basically the incidence or how many patients with acral and mucosal melanoma we enrolled in the study. It was quite a high number, almost 19% of patients enrolled were that, and that will come in handy in later slides. Now, obviously, we want to improve the PFS for our patients. We want to improve the response rates, but we really think about how are we going to improve their survival. We want to cure as many patients as possible. And now that we have 3 years of follow-up, you see on the survival curves, as I mentioned, there was 2 waves of patients, the phase 2 and the phase 3, and that's why you see this pattern of censoring. There's still quite a bit of censoring happening between year 3 and year 4, but that also highlights why the 3-year update is so critical. And we see here, again, a difference in survival that happens early and persists throughout, a hazard ratio of 0.8. And at this point, with enough events, we actually see that the confidence interval does not cross 1 anymore. So if this was not an exploratory analysis, we would say that's statistically significant. But since it's an exploratory analysis, we actually can't say those words, but they do look quite different. And again, the confidence interval does not cross 1. Importantly, the median survival is 51 months versus 34 months. And you see that plateau forming even at the start of the 3-year mark. And when we look at melanoma-specific survival, which is really important, the median age for those patients is 63, so some of those patients die of other causes. When you look at what causes specifically melanoma-related death, you see an even more impressive effect of the nivo-rela versus nivo. The hazard ratio is 0.75. The confidence interval does not cross 1. The median is not even reached, and you see that plateau also that happens starting at 3 years, and it's looking at about 60% compared to 50% for nivolumab alone. So really impressive data for this combination. Obviously, importantly, this combination is safe. That doublet in this case has only about 22% grade 3/4 toxicity. As oncologists, that always gives us a good backbone to add more things on top of it. And what better to add than a checkpoint that's already proven in this setting, which is ipilimumab. So the idea of doing all three checkpoints together has a lot of strong preclinical rationale, and I think biologically it makes sense to try to target these three distinct checkpoints. And BMS ran a trial that was a phase 1 to a degree. I call it phase 1 because it was a safety study, but just to be clear, it was not a dose escalation study. They chose a dose that they treated 46 patients at. And that dose was Nivo and Rela at their standard dose every 4 weeks. And then IPI was added at 1 milligram per kilogram, but was added once every 8 weeks. So it's a really low dose of IPI that was used, clearly because there's a concern about the potential toxicity. The toxicity increased from 22% of what you would expect for Nivo-Rela alone all the way to 39%. So it almost doubled with just 1 milligram of IPI every 8 weeks, but still it's safer than the high-dose IPI-Nivo combination, and yet the response rates that this induced were really high, 59% by investigator assessment, 52% by blinded independent review. But I think what got us all excited as this was presented at ASCO 2024 was these PFS and OS curves that look quite impressive. Median not reached, you see that all the way to 1 and 2 years we're at above 55% for PFS. And then the OS is looking really remarkable. Again, only 46 patients, an early phase study, but just gets you into the space where maybe with the triplets, we will be able to extend or improve outcomes for our patients with higher risk diseases. Now, once you have checkpoint inhibitors in hand, you have to remember that if your patient has a BRAF mutant melanoma, you actually do have the opportunity of thinking about combination BRAF and MEK inhibitors. And so the question is, which one do you use? Do you choose a combination immunotherapy in BRAF mutated patients, or do you use BRAF and MEK inhibitors? And so, again, I'll bring you back to the NCCN guidelines, where it is very clear that the checkpoint inhibitors upfront are the preferred regimen, regardless of the BRAF mutation, mostly because there's been clear evidence and clear data that shows that starting with immunotherapy is the way to go. So let me show you that evidence, and probably best exemplified in the simplest trial and simplest in design and probably the hardest to actually implement. And it took many years to get accrued. But this was a trial that was ran through ECOG with Mike Atkins as the PI, and it was a simple question. If you have a BRAF mutant melanoma patient with metastatic disease up front, you started half of them on IPI-Nivo up front, and you switched at progression to BRAF and MEK inhibitors, or you started with BRAF and MEK inhibitors and you switched at progression to IPI and Nivo. And as we all expected in the first year or so, in the first 10 months, targeted therapy looks a lot better. It works faster, it works more consistently. That control of disease is very limited in time, and in fact, it actually dissipates by 10 months, and the immunotherapy looks like it's giving its typical durable responses, and overall ends up having a 20% absolute benefit in overall survival in favor of immunotherapy. A massive difference, highly statistically significant, and truly highlights the fact that there is no question we should use IPI-Nivo up front for those patients with BRAF mutated melanoma. So an overall survival difference of 20% at 2 years. Now, the interesting part is that as the study was being implemented, there were a significant number of patients, almost 24 patients, that were randomized to IPI and Nivo and ended up progressing so rapidly that they actually died before they got any BRAF and MEK inhibitors. If you see this overall survival curve, you have this upfront drop in survival. And those patients, if you look at their specific characteristics, they were patients with high tumor burden, high LDH. You could have predicted those patients were going to progress relatively rapidly. And unfortunately, that's what happened. And so you could think about a short course of BRAF and MEK inhibitors up front. We know they work in such a high proportion of patients. So if you have a high-risk patient, could you not give them a short course of targeted therapy and then switch to immunotherapy? And that's what the COMBI trial did. It was a study led by our Italian colleagues where two arms of the trial look almost identical to the DREAMseq trial. One was Incobeni, you switch at progression to Ipi-Nivo versus Ipi-Nivo, you switch at progression to Incobeni. The innovative arm here is the sandwich approach, arm C, where you got 8 weeks of Incobeni and then switched before progression. It was a planned switch to Ipi-Nivo as a high-dose combination. And as mentioned in the footnote there, it was almost 40% of patients that had elevated LDH. And what you see from the PFS and the OS curves is very importantly that, first of all, the answer that is almost identical to DREAMseq, which is that Ipi-Nivo up front was better than the arm A that started with Incobeni up front. So clearly consistent, and that reflects what the other study had shown. But what you also see is that arm C, the sandwich arm, looks as good as Ipi-Nivo. So if you did that 8 weeks and then you started Ipi-Nivo, you still ended up with the same PFS and OS that you see on the right. Now, importantly, the study, hugely important, very well done, but it's very small numbers of patients, only 70 patients per arm. And so Caroline Robert just presented the study from the EORTC, which was immediately asking almost the next question, where the randomization here was to Ipi-Nivo versus the sandwich arm. Slight differences in that the sandwich arm was 12 weeks instead of 8 weeks. And then they also used Ipi-Nivo at only 1 milligram per kilogram of Ipi and Nivo 3 milligram per kilogram, so what we call flip dose. So that you would expect to have a slightly different outcome for checkpoint inhibitors, but otherwise very similar. And this one is well designed and powered to show a difference, so 270 patients. And what you see in the outcomes is the high LDH, the high tumor burden, patients with liver metastases. They actually do just as well as the patients on the Ipi-Nivo arm in terms of overall outcomes, and that's reflective of the fact that you could save that population by doing targeted therapy upfront. And I think that's the take-home message from this, that for such a patient population, you may be able to start with targeted therapy, do almost a tumor reduction of sorts, a cytoreduction of sorts before you start Ipi and Nivo. The other interesting component from both studies, and we've been seeing this being looked at by different trials, where we still are not including patients with brain metastases on these studies. We're still excluding them with a brain MRI at the start, but we're starting to collect data on the incidence of brain metastases while you're on treatment. And what you see is this interesting pattern, which is the fact that targeted therapy upfront is associated with a higher incidence of CNS metastases compared to starting with immunotherapy upfront. And that remains an advantage for Ipi-Nivo upfront. The COMBI trial seemed like the sandwich approach really did not affect those patient outcomes negatively in terms of CNS metastases, but in the EBIN trial, it seems like there was a higher incidence of brain metastases if you had started with Incobeni upfront. So that is something to take into account as you think about treatment options for your patients. What is the role of dual checkpoint inhibitor in brain metastases? So this is where the power of immunotherapy really becomes probably most apparent. So this was the Checkmate 204 study we published initially in the New England Journal of Medicine 2018, the original data from the asymptomatic cohort, and then we updated this in 2021 with 3-year data where we showed a high response rate in the brain with Ipi and Nivo. So a response of 55%, a clinical benefit rate of 57% in asymptomatic patients, and responses in the brain were highly durable, so the median actually has not been reached for asymptomatic patients. We also noted that if patients are symptomatic or requiring steroids, the response rates were a lot lower, 20%. And durable when they happen, but a lot lower. So really highlighting the role of steroids in decreasing the benefit from checkpoint inhibitors. The outcomes were confirmed by a smaller study ran in Australia where Ipi-Nivo, in this case it was 27 patients. We had treated on asymptomatic cohort for Checkmate 204 101 patients, but the outcomes are almost identical, 55% response, and you see also the benefit in PFS and OS. The interesting part here is that single agent PD-1 also has a very low response rate in the brain, 20%. That's half of what you get outside the brain with Nivo alone. So just keep that in mind. And definitely using nivolumab alone in patients that are symptomatic, have LMD, are on steroids was really dismal. Only 6% of patients responded, actually 1 out of 16 in that cohort C, and you see their survival looks really terrible. So single agent PD-1, not a good idea for those patients. And then if you look at the survival benefit, on the left, you see a study I didn't discuss in detail. It was an Italian trial that also had about 30 patients with Ipi-Nivo, and you see the survival going to above 50%, all the way to 70% on Checkmate 204 when you do immunotherapy upfront. So really important outcomes, and they look just as good as patients without brain metastases from Checkmate 067. So Relativity 047, one of the studies that I personally led, and we still did not include patients with brain metastases. As I mentioned, we really were interested in the impact of Nivo-Rela in the brain. We don't have the answer in terms of direct impact on existing brain metastases, but we did follow those patients along. And if you look at the incidence of brain metastases, if you got single agent PD-1 versus combination, you see that single agent PD-1 had a higher incidence, up to 27% of patients progress in the brain and only 17% on Nivo-Rela, probably highlighting a differential impact of Nivo-Rela in the brain compared to Nivo alone. And you see on the right also the CNS metastases-free survival. Of course, not significant because we were talking about subgroups that had the appropriate longitudinal imaging, but the hazard ratio is 0.63, indicating that you're almost decreasing the incidence of brain metastases by 37%. And the real question of does the combination of Nivo-Rela work in the brain as well as the combination of PD-1 CTLA-4 really needs to happen in patients that have active untreated brain metastases. So we're running this trial that we affectionately called Blue Bonnet at MD Anderson. It is a study where 30 patients with established brain metastases, asymptomatic, so very similar to the Checkmate 204 population, treated with checkpoint inhibitors, Nivo and Rela in this case, to see the outcome. It's a phase 2 trial. We're about a third of the way through enrollment. And we're hoping to report the results in the next year or so to see if Nivo and Rela has the same activity in the brain as it has outside the brain. We started this discussion around the BRAF and MEK inhibitor combinations and how do you use them in this setting. And honestly, I think it's really the brain metastases that probably explain a significant proportion of the benefit of checkpoint inhibitors over BRAF and MEK inhibitors, as indicated by this study, COMBI-MB. Was a trial that was designed to check exactly the impact of dabrafenib and trametinib on patients with active, untreated brain metastases. And true enough, targeted therapy, as targeted therapy does, you can induce high response rates and you can induce them quickly. So the response rate in the brain intracranially was close to 60%. But what happens is that the progression-free survival is much more limited in time. We just mentioned if you were treating with BRAF and MEK inhibitors, you expect 10 to 12 months of a median PFS outside the brain. And it seems that when you do it for patients with brain metastases, you only get about 5 months. So it's half of what you get outside the brain, indicating that that's the place where you lose control faster. In fact, if you look at the progression in those patients, 3/4 of the time it was progression in the brain. What about PD-1 and LAG-3 combinations? How do we use those practically in our patients with metastatic melanoma? So if you look at the current regimens in existence for Nivo and Ipi, especially the high-dose Ipi-Nivo, 3 milligram per kilogram versus plus 1 milligram per kilogram of Nivo. Together, we know that there's 4 induction doses. You do them every 3 weeks. With Nivo and Rela, nivolumab standard of care, you can give it 240 at every 2 weeks or 480 every 4 weeks. We really have not used the 2-weekly regimen since the 4-weekly regimen has been approved. With Nivo-Rela, you can use the same exact 4-weekly regimen. So it's 30-minute infusion every 4 weeks. It's a fixed dose combination. The 2 drugs come in 1 bag. And we're all interested in the new approaches where you can deliver some of these drugs subcutaneously. Obviously, that has different pharmacodynamics, and the dosing is being confirmed right now in different studies, including RCC trials and melanoma trials. So we'll see if this ends up being an approved regimen where you can deliver this subcutaneously, and that will become even easier for patients over time. One of the biggest issues we think about with any sort of immunotherapy, and surely with combinations, is the management of toxicity. And I want to spend just a couple of minutes thinking about toxicity and how we manage it. Generally speaking, grading toxicity is very important. It is actually the first step towards the best possible way you can manage those toxicities. Grade 1 is typically very, very mild, so just the existence of any evidence of toxicity. So we start talking about early rash or sometimes loose stools, something like this, or a slight elevation LFTs. And then this becomes a little more significant with grade 2, again, with higher LFTs, maybe more consistent loose stools. But the important thing is, I think, learning when to withhold immunotherapy has really helped decrease this transition from grade 2 to grade 3 or 4. So noting these things, educating patients, and being aware of early grade toxicity can really help stop immunotherapy and potentially withhold it just for a couple of weeks, sometimes a month, and you can actually get your patient back on treatment and prevent the full evolution of grade 3-4 toxicity. But again, as soon as grade 3-4 toxicity sets in, you really have to stop immunotherapy, immediately resort to steroids, and really think about ways that you could manage this potentially outpatient. But I don't think twice about admitting patients if I think that they're sick enough and they need a fast resolution of their toxicity, whichever toxicity that is. So hospitalization, if it helps, should be definitely considered for patients with high risk and high grade toxicity. Now, when we think about Nivo and Rela specifically, you don't dose reduce, you just hold. And I think holding is entirely fine. And sometimes I've held an entire dose, so 4 weeks, sometimes shorter duration, depending on how severe the toxicity is. And of course, if you hit anything like grade 4 or some of these really terrible grade 3s, you may want to stop entirely your patients and maybe either go to a different combination or to targeted therapy if the patient still needs management. So re-challenge is something that I occasionally do depending on how quickly I manage to manage the toxicity. I manage to bring patients off steroids, and sometimes I've re-challenged for both diarrhea, for hepatitis as well, but those are very unique situations and one have to be very careful in those settings. Now, when we think about toxicity, that's where immediately those two regimens of Nivo-Rela versus Ipi-Nivo come to mind. Every single time we think about using Ipi-Nivo at a high dose, the immediate thought is how much of a toxicity are you going to cause? And I can tell you it's been very consistent. It's 55% grade 3-4 toxicity. And in my experience, almost all of them happen in 2s and 3s, as in more than one toxicity at a time. Nivo and Rela definitely has an advantage there. It's 22% grade 3-4 toxicity. The pattern of the toxicity is very similar to what we see with single agent nivolumab, which I think is really important. Higher incidence for sure, but on a patient-to-patient basis, it almost feels identical. And then you say, well, maybe if I use the lower toxicity regimen, maybe I'm compromising on efficacy. So BMS did this interesting analysis that I participated in. It's called an indirect treatment comparison. And they took advantage of the fact that they have the primary data on all of the patients that were treated on Checkmate 067 and the patients treated on Relativity 047. And the first thing you do is you compare the two control arms, nivolumab, and both control arms were actually identical, which is what you want to know and you want to see. But importantly, what we saw is also like from a PFS perspective, even from an objective response perspective and an OS perspective, Ipi and Nivo was actually comparable to Nivo and Rela. The hazard ratio is almost 1 for every analysis. And there was no evidence that there was a true difference in favor of Ipi-Nivo. So maybe early days, I still think Ipi-Nivo has potency. It's a combination I resort to regularly, but it's food for thought to say that it's almost a third of the toxicity, and yet it can still give you some similar benefits. The one thing I've learned over my almost 15 years of doing this is to ask for help. And grade 3, 4 adverse events are not to be managed by the oncologist on your own. I mean, there are a lot of people that need to be involved, and I really resort to phoning a friend relatively regularly. Of course, our teams in the clinic, our oncology nurses and pharmacists are really highly important. But we also need dermatology. I rely on radiology a lot for diagnoses. I rely on biopsies from pathologists as well. But I regularly reach out to our endocrinologist or specifically our GI colleagues for colonoscopy and biopsy. So it is a really important multidisciplinary approach to think about toxicities, and asking for help and asking for clarifications on diagnoses early on, I think, is very, very important and can help you manage those patients better. So our next segment is to talk about how to align frontline care using the latest evidence and the guidelines. So I'm going to talk through 3 cases specifically with different permutations so that you can get a sense of how I practice with the evidence that we have. So here's a patient who's 62-year-old, recently diagnosed with metastatic melanoma. She's previously untreated. Her CT of the chest demonstrates lung lesions. The largest is about 2 centimeters. You have an elevated LDH affecting her performance status to PS of 1, and she does not have a BRAF mutation in her tumor. So what would be the assessment here? So first of all, you have to think about which regimen would make the most sense. I don't consider single agent PD-1 any longer in patients with metastatic melanoma. We have phase 3 evidence in favor of combination therapy from the days of Checkmate 067, but now a study that's designed specifically to prove the superiority of a combination over single agent PD-1, relativity over 7, was very positive and very clearly in favor of combination. So I really don't think single agent should be considered at all. The main question in this patient, do you choose combination nivo-rela or combination ipi-nivo? And technically, either of them would be appropriate. A quick point here is I would not consider low-dose ipi-nivo as a reasonable regimen. Again, if you resort to low-dose ipi-nivo, it's because you're afraid of toxicity. And if that's the case, you have nivo-rela in hand, and that should be your go-to regimen in case you're afraid of toxicity. In this particular patient, 62 is not particularly old, and if she otherwise doesn't have any significant comorbidities, a PS of 1 is not enough to deter me. But with only lung metastases and her being relatively asymptomatic from her disease, I would consider nivolumab and relatlimab for this patient. If you choose ipilimumab and nivolumab, it is not wrong in any way. And by the way, we don't mention the brain metastases here. I'm assuming this patient does not have brain metastases. What about if Mary was 82 years old and now her PS is actually 2? So we're getting into a place where high-grade toxicity can really become dangerous for this patient, and it could really impact her negatively. Definitely in the elderly range, and definitely has the limitation to her performance status consistent with advanced disease. I think in a patient like this, resorting to a regimen that has 22% toxicity with nivolumab and relatlimab is a really good option. I would immediately do that, knowing that in the second line, and we didn't go over this data today, but in the second line, IPI and Nivo, after Nivo-rela, we had presented at ASCO last year and updated at ASCO this year, still has a 25% response rate, where the opposite may not be true. If we do IPI-Nivo up front, first of all, you have more toxicity. Second, Nivo and Rela in the second line seems to have only a 12% response rate, so we have to take that into account. So I think for this lady, if she was 82 with a PS of 2, I think it would be a very clear direction for me to go with nivolumab and relatlimab. And if we look at the subgroup analysis as well, lung-only disease had a 54% response with nivo-rela. So again, I think we would benefit this lady that way. So now we go to our second case in which we have a bit more nuance. We have a BRAF mutated melanoma, and in a patient who is 50 years old, normal LDH, slight performance status of 1, But in this case, we have multiple liver metastases. And again, we have a BRAF mutation in hand. So the first question is, do we start with immunotherapy or with BRAF and MEK? And so I showed you 3 different trials that have tried to answer this question. I think DreamSeq did not just try, but clearly answered this question in favor of Ipi/Nivo. And in this particular patient, it doesn't seem like his performance status is particularly advanced or affected. This is a patient who's young and should be able to tolerate Ipi/Nivo up front. We were not given any sort of evidence in terms of the pace of the disease. Sometimes you have a prior scan from 3 months ago that can tell you if there was any significant progression in the liver. Maybe the liver makes you think twice, but really, I think for someone like this, Ipi/Nivo up front makes a lot of sense. If there was evidence of a high pace of disease or a highly symptomatic patient, sometimes now you can rely on Secombit and Eben to say maybe we'll give 8 to 12 weeks of Incobini before we start Ipi/Nivo. And the question of PD-1 lag, I think, is the most interesting one, because all these 3 trials have you really used a combination of Ipi/Nivo. But if anything, I think the Eben trial highlights that even the low-dose Ipi/Nivo still had an advantage over targeted therapy. I really think that it's a class effect in this case. It's immunotherapy that's being able to give the long-term outcomes. It's not necessarily whether it's PD-1 lag or Ipi/Nivo. So I do consider PD-1 lag in this setting almost as interchangeable with Ipi/Nivo based on the trials. I can assure you we're not going to run trials comparing Nivo-Rela to BRAF and MEK. I think it's no longer ethical to randomize a first-line patient to BRAF and MEK, so we're never going to have that answer directly. I do think that PD-1 and lag are very similar to Ipi and Nivo. I mentioned that because of the liver burden, this is a patient, if you have a bit more concern about how well they'll do in the short term and whether they'll benefit from immunotherapy, it is not wrong at this point in time to do a short course of targeted therapy up front before you switch those patients to immunotherapy. We move on to a case with brain metastases. So 67-year-old with metastatic melanoma, initially presented with lung mets, and that's very common. Lung mets are first and then brain mets come immediately after. This was found on screening. The patient was asymptomatic, generally good health, only hypertension, and has BRAF mutation in their tumor. So what would you use for this patient, immunotherapy or BRAF and MEK? I hope I made it very clear that in this case, Ipi and Nivo or Checkmate 204 ABC has been very clear in terms of the value of Ipi and Nivo for this population. You could use targeted therapy, but that would be suboptimal. You would get progression faster. I would even surmise that we showed some of this evidence that some of the reason that checkpoint inhibitors work better in the first line than BRAF and MEK is their impact in the brain, because they're more effective in the brain than targeted therapy. Targeted therapy will give you quick responses, but it will not give you long-term benefit. And so if this patient was highly symptomatic, requiring steroids, and had a BRAF mutation, one could extrapolate from Secombit and from Eben and say maybe if you give them targeted therapy to shrink down the brain metastases, take the steroids off, and switch them to checkpoint inhibitors, you would give them the best benefit. And that would be one consideration. But ideally, get them immunotherapy as quickly as possible. With the available evidence, Ipi and Nivo, and specifically high-dose Ipi 3 mg per kg, and Nivo 1 mg per kg is the preferred regimen, the standard of care. And there's no data yet for Nivo-Rela, but that's evolving at this time. I would say for this patient, the standard of care is Ipi/Nivo. If the patient has a wild-type BRAF, as I mentioned, as long as they're not requiring steroids, it's not the performance status or the symptoms, it's whether they require steroids or not. The evidence is very clear in the presence of steroids, Ipi and Nivo is not going to be effective. So if the patient has a need for steroids, one of the ways to think about it is how do you eliminate that? And we've thought about either surgery to take the tumor out or radiation therapy and then coming in with immunotherapy. And that would be an appropriate way to manage this patient. The one thing I say, just like I mentioned in the case of toxicity, phone a friend, I would say for this, absolutely multidisciplinary care involving radiation oncology and neurosurgery, incredibly important for the management of those patients. I always learn so much from our colleagues. And with my experience in this space, I still feel like I can't make that decision without checking in with them just to make sure that we're not starting systemic therapy in a place where radiation could offer more benefit in the specific location of a brain metastasis. On the other hand, our colleagues in radiation oncology and neurosurgery have recognized the role of systemic therapy. And really, we work together in terms of getting immunotherapy to those patients as quickly as possible. So with that, I will just leave you with a few take-home messages. I clearly think that checkpoint inhibitors are our best tool to offer our patients long-term survival with metastatic melanoma. That's been proven time and time again. And now with new combinations, we have overall survival benefit. And we've seen with combination immunotherapy an overall survival benefit over targeted therapy. And now we have PFS, objective response, and even OS benefit over single agent PD-1. So I think the era of single agent PD-1 is over as well. Combination PD-1 CTLA-4 is what offers us so far the highest response rate, and definitely is currently our best choice for brain metastases until we have evidence of the role of nivo and rela in the brain. But as I said, there's very little role for single agent, for monotherapy that's left in the first line setting. Regardless of age, comorbidities, performance status, nivo-rela or PD-1 LAG-3, their safety profile is really not very different. 5-7% grade 3-4 toxicity difference, almost not evident on a patient-to-patient level. And I think that combination offers so much more benefit over a single agent. Obviously, the toxicity of PD-1 CTLA-4, the grade 3-4 toxicity is still high, 50-55%. PD-1 lag only 22%. And again, I really don't see where low-dose ipi-nivo fits here at all. Low-dose ipi-nivo still has a toxicity that's actually worse than PD-1 lag-3. In the Checkmate 511 study, it was still about 35%. And again, I showed you that efficacy for PD-1 CTLA-4 at the high dose seems about the same as PD-1 lag. So to me, low-dose ipi-nivo could end up being a more toxic and less efficacious regimen than nivo-rela. So I don't use that any longer. When I'm trying to choose between PD-1 CTLA-4 and PD-1 lag-3, I really think about every single one of those issues that we discussed, the pace of the disease, the LDH, the number of tumor sites that are involved, and then which patients am I treating? What is their potential tolerance for immune-related adverse events? Is my team prepared? Are the patients prepared to manage them? And if we are, then that helps make that decision between those two combinations. So with that, I thank you for your attention. This does conclude our exploration of the modern use of combination immunotherapy and metastatic melanoma. I hope you found this activity informative and useful for your practice. Make sure to download the tools that were available to you through this program, and thank you so much for your attention.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported through an educational grant from Bristol-Myers Squibb. To access all materials for this activity, visit peerview.com/RQT860.